Acute myeloid leukemia is a hematological disease focusing on myeloid cells, and it's characterized by a different mutation which occur in the hematopoietic stem cells, but also in the hematopoietic progenitor cells, and to completely disrupt the, let's say, differentiation of the normal hematopoiesis into neutrophils, platelets, and red blood cells. And this results in the most common symptoms of acute myeloid leukemia. So if we have a decrease in platelets, bleeding may occur. If we have a decrease in neutrophil count, an infection will occur. And if we have a decrease in red blood cell count, then we have dyspnea, tachycardia, what we know, the results of anemia. Acute myeloid leukemia is a disease of older patients. The median age is 70 years. So half of the patients are older than 70 years and half of the patients are younger. Most of the research was done in younger patients so far. Acute myeloid leukemia is very dismal, is associated with a very dismal prognosis if not treated. Patients who are not treated, and this we know from the 1970s and 1980s, where we just start to treat acute myeloid leukemia with chemotherapy, half of the patients were dead within 3 months. And acute myeloid leukemia has to be urgently treated with intensive chemotherapy, and this is done normally on an inpatient basis. Acute myeloid leukemia has an incidence is reported between 3 and 4 per 100,000 men and women per year. However, it may differ a little bit according to country. For example, in south of France, incidence of 2.0 to 2.5 has been reported, whereas in the US, compared to the US, there an increasing incidence has been reported with up to 4.4 per 100,000 inhabitants. Acute myeloid leukemia can be distinguished in 3 broad groups. The first group is newly developing acute myeloid leukemia called de novo AML, compared to, for example, a treatment-related AML. These are AMLs occurring after patients received intensive chemotherapy or radiotherapy for other malignancy or another disease. And finally, there is a third group of patients which can be distinguished. These are patients who develop an acute myeloid leukemia from another myeloid disease, either from a myelodysplastic syndrome or myeloproliferative disease. The heterogeneity of the disease was early identified, and this was done by morphology, and this was introduced in the, let's say, classification of acute myeloid leukemia in the 1970s with the French-American-British classification. This only looks at morphology. However, already 7 subgroups were identified. And over the years, more and more, we learned that there is an enormous heterogeneity if we look at the genetic background of the disease. We identified type 1 mutations which induce proliferation and block in differentiation, and type 2 mutations, for example, who impact on self-renewal and also differentiation. However, additional mutations are coming up, interfering with epigenetics. So we know now, for example, mutations coming up in ADH1 and ADH2, but also TET2, and they interfere with the epigenetic makeup of the disease. So if we look at the heterogeneity, different group of mutational classes can be classified. However, this process is still ongoing because the heterogeneity and in the prospect of specific inhibitors, this is an ongoing process. Acute myeloid leukemia could first treated in the 1960s to 1970s, where cytarabine and also anthracyclines were introduced in the treatment of acute myeloid leukemia. Before that, patients really had a dismal prognosis, and half of the patients were dead within 3 to 6 months. So with only supportive therapy, the prognosis is very dismal. Then with the chemotherapeutic agents in the late 1990s, the prognosis could clearly improve because for the first time with intensive induction therapy, complete remissions could be induced. So a complete remission means that the disease is no longer identifiable in the bone marrow smears and also in the peripheral blood smears. However, we learned very rapidly that without consolidation therapy, all patients will relapse. And then in the late 1990s, intensive consolidation therapy was introduced. However, focusing on acute myeloid leukemia of the younger patients, the prognosis improved. In contrast, in older patients, still the prognosis was very dismal after all this chemotherapy given. For example, the 5-year survival was below 5% in patients above the age of 60, even 10 years ago. And now I think this more and more changes this landscape. First of all, even older patients received as a consolidation therapy allogeneic transplantation, which is a very important treatment component in acute myeloid leukemia, but also targeted agents are now included in the treatment landscape of AML and thus will gradually improve the prognosis.